So my name is Colleen Campbell. I'm a nurse practitioner that works with the cancer program. What today's class is about is colorectal survivorship. So folks get a diagnosis of colorectal cancer. They go through surgery. They may or may not have radiation. They may or may not have chemotherapy. And you come to the hospital for all those visits and you see the doctors. And then you're done your treatment. And then what? Right? What is surveillance? What do I need to do to make sure that this cancer doesn't come back? What can I do? What are my healthcare providers responsible for? And this class is to try to put some of those things together for you and help you to be better informed so that you can be an advocate for your own health. So there's several things involved in survivorship. There's looking for cancer recurrence, so we want to make sure that that cancer doesn't come back, and there's a number of things we do to watch out for cancer recurrence. We want to manage the effects or the late effects of treatment, so there can be some late effects to having radiation, and there can be some late effects to having chemotherapy that may not show up for years later. So I think it's great for you to be informed so that if something does come up, you can go, oh yeah, I had that chemotherapy 10 years ago. Could that be related? The other thing is looking after your physical well-being afterwards. So we talk about diet, and we talk about exercise, and looking after your emotional well-being. Cancer doesn't affect you just physically, it affects you emotionally, and it affects you and it affects your family. So I think it's really important to be aware of how cancer affects you and some strategies to cope with that. And there's lifestyle changes. If you were left with a colostomy or your bowel movements now come out through a pouch instead of coming down through your rectum, then there's certainly lifestyle changes, and that affects many areas of your life. So we'll talk a little bit about that as well. So we'll go through the gastrointestinal system in case you're just not clear where everything is. We'll talk about the surveillance guidelines and what we should do to monitor that the cancer isn't coming back. We'll talk about some of the survivorship issues, so the late effects of chemotherapy, radiation. We'll talk about exercise, managing your emotions, diet, and ostomy care, and we actually have experts in all of those fields to come and talk to you today. You need to know when to get help, and you need to know what your resources are, so we'll cover that briefly. So the gastrointestinal system. So everybody stand up. This is a participation sport, right? Tucked underneath your ribs is your liver, right? So underneath the right side of your ribs are your liver. Right side, yeah. Okay, so that's your liver. Your stomach is right in the middle. So right in the middle is your stomach. Your stomach is connected to your small bowel, right? So that's all those guts that are all kind of in the middle there. It winds around, I think there's miles and miles of it. And that connects down to your large bowel. Your large bowel is down in your right lower quadrant, where your appendix would be, right? So that's where your large bowel starts. Your large bowel, your ascending colon comes up towards your liver, and then it makes a big turn. Your transverse colon goes across your body to the other side, where your spleen is, makes a big turn, goes down the left side, and connects to your rectum, where the bowel movements are held, and then your anus is a sphincter that lets things go. So your colon cancer is either your ascending, transverse, or descending colon. Rectal cancer is in the rectal part, the very bottom part. Okay, you can sit down. Well done. So surveillance. Once you've finished your treatments, be it just surgery, be it surgery and radiation with plus or minus chemotherapy, we do surveillance in a couple different modalities. First is a colonoscopy, and I know you all are familiar with colonoscopies, right? That's the camera that goes in the backside and has a looks up into the large bowel and across and down, several feet of it. Colonoscopy should be done within a year of your initial surgery. Your surgeon or your endoscopist is looking for any recurrence, so where he attached the bowel back together or where he snipped the bowel off, looking for cancer if it's come back. And he's also looking for polyps, right? Polyps are those little mushroom things that grow into your bowel. Oftentimes polyps will turn into a cancer, so if they see the polyps, they snip them off. It takes about 10 to 15 years for a polyp to turn into cancer. So the colonoscopies can be done at 1 year, 3 years, 5 years, depending on what the physician sees and how long he thinks you should go. So usually about the first year after treatment, or first year after surgery, and then at his discretion between 1 and 5 years. for the foreseeable future. If you had a rectal cancer, you have a sigmoidoscopy, which is a shorter camera, and it just goes into the lower bowel, and that's usually done at least every 6 months for 2 years, and then a little less often to finish up the 5 years. Every 6 months, according to our guidelines, our national guidelines, you should have a history, so to see a healthcare provider, whether it be a physician or a nurse practitioner. Review your medications, review how you've been feeling. We're looking for signs of recurrence, and we'll talk about that in a little bit. A physical examination, right? Want to listen to your lungs, make sure they're clear. Want to feel that liver, make sure it's not large or giving any problems. And we want to do a CEA, a carcinoembryonic antigen, is a blood test. It's like a tumor marker in the blood for colon cancer. It's not a specific enough test that we could give one to everybody and find out who has colon cancer and who doesn't. But once you've had colon cancer, it's a specific enough that if we see a trend, that number is going up, then we know to look a little bit closer to see if the cancer's come back. So we usually do that between every 3 or 6 months for a total of 5 years. We do the history, the physical, and the CEA tests, as I say, every 3 to 6 months for a total of 5 years. The point we really want to emphasize with this slide as well is that you should still see your primary care provider, your family doctor or your nurse practitioner, because your exams with us are very focused on colon cancer. You still need your blood pressure checked, you still need your cholesterol checked, you still need all those things, your flu shot. You should still keep in touch with your family doctor and have regular visits with him or her. Once a year, after you've had your treatment, we like to do a CAT scan. So a CAT scan looking for distant metastases or the colon cancer, make sure it hasn't traveled to your lungs, making sure it hasn't traveled to your liver. We usually do it once a year at least once a year for a total of 3 years. Your chance of having the cancer show up elsewhere in your body after 3 years drops off significantly. If you can't have CAT scans, your kidney function maybe is not 100%, or you're not able to have a CAT scan, we can do an ultrasound of the liver and a chest x-ray, and that's adequate as well. So how do you keep track of all these things? As healthcare providers in the cancer system, we dictate everything in a note, and we pass that along to your surgeon and to your family doctor. We try to share information as best we can. But as you know, with institutions and organizations, it doesn't always work the best. So it came up with a little colorectal surveillance clinic follow-up tracker. And this is something I've started handing out to folks that come to our clinic. And on the inside is just your information, your name and your surgeon and your endoscopist, the date of your surgery, if you had chemotherapy or not. And inside is an area where we can track your history and physical, your blood test, your CAT scans, and your colonoscopies for the 5 years. So what I'm doing now is handing this out and filling out the CEA result at each visit, filling out the CT scan date and time at each visit, filling out the colonoscopy, and then you would keep this and you would bring it back at your next visit and we would update it. And that way you always have a current information on where you are in your surveillance program. Late effects of surgery. So if you've had surgery, you know that it can cause a change in your bowel function, right? You have a little bit shorter bowel that you're working with. Most times people will change with more frequent bowel movements. Sometimes they have looser bowel movements. There is the odd time where people have constipation or they don't move as well. And that's fairly normal after surgery, and we try to work that out with diet and exercise or medications if needed. You might have more gas or bloating. You may end up with a hernia, and a hernia is a weakness in the stomach wall, generally where you've had your surgery, they've sewn you back together, but it's become a little bit weak in that stomach wall, so you might have a bit of a pouching when you put pressure on your abdomen, and that's a hernia. Risk of obstruction, so you know when you cut yourself and you get a scar and things kind of pull in towards the scar, that can happen after surgery as well on the inside of your body. So you may get scarring and the bowel sort of sticks to the side of your abdomen or what have you. So not a problem, but it can sometimes cause you some pain when you're moving a different way, and it sometimes can cause the bowel movements to get stuck and not move through the way they should. You will have pain, you will know if this happens to you. But it is one of the late effects. And change in lifestyle. If you're left with an ostomy, again, a hole in the side of your abdomen where your bowel movements come out, then certainly those big changes after surgery. Late effects of chemotherapy. If you received oxaliplatin for colon cancer, you have numbness and tingling of your hands or feet. This often will go away at the end of treatment. It can go on for 4 or 5 years after treatment, and it can sometimes be forever. So we really have to counsel people on how to live with now this neuropathy or this numbness and tingling in their hands and feet. Difficulty with short-term memory. We have, again, sort of something that the cancer world is investigating more is called chemobrain, or cognitive dysfunction because of chemotherapy. Generally speaking, you may have trouble remembering people, places, things for about a year after chemotherapy, and then it sort of works itself out and things are okay. If it should go on longer than that, then it requires some more investigation. Still, research in cognitive dysfunction after chemotherapy is still fairly new. We don't have a lot of information on it. Late effects of radiation. So generally people who have had rectal cancer will have radiation. And so if you think of radiation beams coming to that part of your body, what could be some of the late effects? Well, again, increased bowel movements, but also urgency, right? So you've had radiation, that sphincter is maybe not working as well. So when you have to go, right? A 25% chance of that happening after. Risk of bowel obstruction, again, less than 1%, but if you had surgery down there, so you have a bit of scarring and you have radiation that sort of shrinks things up a little bit, it can also cause obstruction. Not often, very rarely, but it can. Induced menopause or transient low sperm counts, and again, you think of your anatomy, you've got ovaries down there and so forth. If they get radiated, then it does cause changes. Secondary cancer, so there is, again, a less than 1% chance that 15, 20 years after your radiation, you actually come up with a second new cancer in that area of radiation. And weakening of the pelvic bone. So if, again, the radiation field goes through your pelvis and it goes through your bones, it can cause those bones to be a bit more brittle than your other bones, so you have to be aware of fracture. Signs of recurrence, and this is, I have trouble with this, right? Because signs of recurrence are really sort of vague. And when I tell people, they're like, oh my gosh, I have a cough and I have nausea. And so we all have these symptoms that I present, but it's more the persistent symptoms, right? So I have a new cough, and nobody else in my family is ill, and I've had it for a couple of weeks, and it keeps getting worse. What are you going to do? You're going to call your doctor, you're going to have a chest x-ray, right? Unexplained fatigue or nausea, all of a sudden you're not able to eat your meals. Again, it goes on for a week or two, it's not getting any better, you need to see your doctor. Weight loss that's unexplained, abdominal or pelvic pain that doesn't go away. Sciatica is that back pain that runs down one side of your buttocks and down your leg. If you develop that and it's severe, you should have it checked out if you've had a previous history of colon cancer, colon or rectal cancer. And difficulty or change in urination or bowel movements, and you folks know that. So we know some of the signs of recurrence, but how do we decrease that risk? Well, it's pretty simple, right? You manage your weight, you get some exercise. There's lots of literature coming out tying exercise to decrease of cancer recurrence. Good nutrition, which we'll talk in more detail about. Stop smoking. Smoking's tied to a lot of cancer. Stress management, and limit that alcohol intake. It's really important, being survivors or family members of survivors of colon cancer, you need to pass on to your family and friends how important for screening for colorectal cancer is. And so we're going to take the next few minutes just to go over that so that you can explain to your friends that it's really important to have colorectal screening. If you have a colon cancer, catch it early and not have to go through the soliloquy.
Hi everyone, so my name is Brittany. I work over in cancer prevention and screening in the Cancer Center. I'm just going to take a couple minutes to highlight the difference between an average risk colon cancer screening and those of increased risk. And I'll talk quickly about some other cancer screening programs you might be eligible for. So average risk colon cancer screening is for men and women ages 50 to 74. And our increased risk colon cancer screening is for those that have a family history of colon cancer and a first-degree relative. So either a parent, a sibling, or a child. So screening for that will start at either the age of 50 or 10 years prior to their family member's diagnosis, whatever occurs first. So if my mother is diagnosed at 52, I would start my colon cancer screening at the age of 42. However, she wasn't diagnosed until 65, I would start mine at 50 because that comes first, then 55. So those with average risk screening, they will do a fecal Olcott blood test, and that's an FOBT kit. It's a very simple at-home test. It's a stool sample over 3 days, and they're going to repeat that every 2 years. Those with an increased risk, they'll require a colonoscopy. Generally, it's every 5 to 10 years, but it could be sooner depending on what the endoscopist says, according to their results. So those that require the FOBT kit or the average risk, they can either pick that up from their family physician, or if they don't have a family physician, they can get that from any pharmacy in the area. They are able to distribute that. But those that need a colonoscopy, that will require referral. So they'll just need to make an appointment with their primary care provider and get the referral for that. And of course, if they have any questions or concerns specific to their health, just to direct them to their primary care provider. These are guidelines that are set out by Cancer Care Ontario. But again, any specific questions, please speak to a primary care provider. So the reason that they have different guidelines for those with an increased risk, they believe that about 10 to 15% of colorectal cancers occur in those people with a family history. So if you have any family members that began screening with an FOBT at the age of 50, they will need to stop screening with that and move to the colonoscopy. And again, screening is just for those individuals that have no sign or symptoms. So they feel well, we're just going to screen for what we can't really see on the inside and try and catch it early, as Colleen mentioned. We also have 2 other screening programs in Ontario. One's for breast cancer screening and the other's for cervical cancer screening. So our OBSP, our Ontario Breast Screening Program, starts at the age of 50 and goes till 74, and that women will receive a mammogram every 2 years. We also have a high-risk program for women ages 30 to 69, and they will receive a mammogram and a breast MRI every year. We also have the cervical cancer screening program, and that starts at the age of 21 for women who are or have ever been sexually active, and they'll require a Pap test every 3 years. So again, please speak to your primary care provider and see if you're up to date on those 2 cancer screening programs.
Hi, my name is Susan Travanut. I'm an occupational therapist and combined decongestive therapist here at the Simcoe Muskoka Regional Cancer Program. And I'm going to talk to you for the next 15 minutes about exercise after colorectal cancer treatment. The objectives for our short talk are threefold. First, we're going to review those side effects after cancer treatment, talk a little bit about the benefits of exercise after cancer treatment, and hopefully at the end of the 15 minutes, you'll have an idea of which exercises are of the most benefit for you in preventing recurrence or preventing the development of cancer. You'll know how to monitor the intensity of the exercise in which you're participating, and finally, you'll know how to progress your exercises safely for maximum benefit. So first thing we need to define is, what is exercise? Most people say to me when I ask them, are you exercising? They'll say, I'm really physically active. But it's not enough to be physically active. Physically active just means you have enough energy to get through your day and do your daily activities. What the research has shown is that you need to engage in moderate physical exercise 3 to 5 times a week. And for colorectal cancers, they've actually shown that something as simple as 6 hours of walking a week can make a huge impact on recurrence of cancer and development of colorectal cancers. So in order for your activity or your exercise to count, to be physical exercise, it has to be planned. There has to be a goal in mind, and it has to be performed to achieve a certain level of fitness. And how we monitor or evaluate whether we've met that level of fitness is we look at different physical fitness attributes. So most people are most familiar with initiating an exercise routine because they want to lower their blood pressure or they want to lower their cholesterol level. But you can also measure things like cardiovascular endurance, muscle strength, your breathing rate. All of those things can be different attributes that you monitor to see if the effort you're putting into doing the exercise is actually giving you the return that you want. Okay. So some of the side effects associated with cancer treatment include pain and fatigue, and that can be immediate or long-standing. You may have changes to your heart and your lungs that affect your energy level or your strength. Additionally, changes in body may occur, may be related to surgery, there may be some scar tissue and some restrictions in terms of range of motion, or you may have had some fat mass increase or lean muscle loss, again contributing to fatigue and decreased energy. Bone metastases sometimes develop so that patients may be at risk, or survivors may be at risk of developing a fracture, and they may experience bone pain or joint pain years or weeks or months after their chemotherapy or radiation. Additionally, some people are left with sensory changes that affect their ability to perform daily activities, such that they feel burning sensation or pins and needles or numbness. And it can have a huge impact on your balance and your sense of where your body position is in space for when you're walking, and also when you're doing daily tasks. You may be more reliant on your visual system when just touch alone can't tell you what you're feeling and where your body is. Later effects can also include emotional issues like depression, anxiety, and stress. And I don't bring up the side effects of cancer treatment to highlight all the trials and tribulations, but instead to focus our thoughts on the idea that research has shown that physical exercise, being active, can counteract all of these symptoms and side effects. So not only do you have less intense experience of these side effects, but the duration from which you're suffering with those side effects may be shortened if you're physically fit. So you have a general sense of enhanced well-being. You feel better about yourself. You look better when you look in the mirror. You have a better body composition, improved self-esteem, better body image. You may gain or lose weight depending on your personal goals, maybe reduce your BMI to reduce your risk of developing certain cancers or other health conditions. As well, exercise can help decrease the effects of nausea and fatigue that we know are sometimes associated with chemotherapy drugs. And it also might help you sleep. So if I haven't convinced you yet that you need to exercise, I'm going to reiterate again, you can decrease your cancer risk, you could reduce your risk of recurrence. In general, you know you're going to get back to your level of functioning faster if you're physically fit. And exercise is one of the most easily modified risk factors. You can't do anything about your genetics. You may have been born with certain DNA that predisposes you to developing certain types of cancer, but you can control and make a choice about how much you're going to exercise and what kind of exercise you're going to do. So I've never exercised before in my life. What do you mean I have to exercise? What does that look like? Keep it simple. It's really simple. You want to do a slight warm-up and stretch so that you don't damage or have injuries to your muscles. You're going to incorporate some aerobic conditioning. You're going to incorporate some strengthening so you have strong muscles and strong bones. And you're going to have a cool down. No jarring starts and stops. Seems a little too simple, but we're going to get a little more complicated. I mentioned the moderate intensity level piece. So the research again has shown somewhere from 50 to 85% of your maximum heart rate or moderate intensity level is what gives you the most bang for your buck. And for those of you who are more focused on objective measures, we're going to use that worksheet and we're going to talk about how you monitor your heart rate and how you figure out what your target heart rate zone is. But for others who just like to keep things simple, ask yourself 3 questions. Am I perspiring lightly? That indicates that you're putting some more effort and exercising at what we assume is a moderate intensity level. Are you breathing a little harder? So you have an increased breathing rate, but you still can carry on a conversation. You do the talk test. And finally, you're comfortably tired, but you're not exhausted after you've done your exercise. Okay? Some people are not as intuitive and they're more of a visual learner. You want to find yourself somewhere in the middle where the gentleman, he's working hard, but he's not just standing around doing nothing, and he's not so tired that he can't get off the couch. So no couch potatoes, but somewhere in the middle is where you want to be. Working a little hard, but not too hard. Now this is where the worksheet comes out. So I don't know if anybody in the room knows how to calculate your heart rate, but great, I see some heads nodding no or saying no. So we're gonna calculate our heart rate together. Very simply, you count beats per minute. So you can either, I see somebody reaching. You can either look for your jugular pulse or your radial pulse. I like to use 2 fingers. Don't use your thumb because you have a pulse in there and you can get kind of confused. So feel around and see if you can find a pulse. Mine's pretty strong because I'm nervous. I love your talking. Okay. When I say go, I want you to count how many beats you feel and then keep the number in your head when I say stop. Ready? Go. And stop. How many beats did people get? 16, not bad. Okay, I count, sorry?
11.
Ooh, good for you. You have a lower resting heart rate. Mine was 12. So in order to calculate how many beats per minute, I counted my beats for 10 seconds. There's 60 seconds in a minute, so I'm going to multiply 12 by 6. My resting heart rate, or my presenting, standing up here talking to you heart rate, would be 72 beats per minute. Okay, so that's step one, just knowing how to check your heart rate. And you're gonna stop in the middle of your exercise and do that occasionally if you really want that objective. I wanna know for sure, am I in the right zone? If you don't wanna know if you're in the right zone, are you sweating? Are you breathing a little harder? That's good, okay? So now we're gonna do the hard part. We're gonna target or calculate your target heart rate. Was there a question? No, okay. Okay, so you need to know what your maximum heart rate is. And for anybody who's breathing, it's a really simple calculation. 220, take away your age. So we're going to round up and say I'm 40. And, my maximum heart rate today is 180 beats per minute, okay? That is way too high for me to be exercising at a sustained level. That's not a moderate intensity level. And it can actually have detrimental effects, immunosuppressive effects on my blood and on my body. So I don't want to be up at 180 beats per minute for a lengthy period of time. Instead, if I've been moderately physically active, I can target somewhere in the 60 to 85% range of my maximum heart rate. And how you calculate that is you take that number, 220 minus your age, for me it was 180, I multiply it by 60 or I multiply it by 0.85 and I get my number. Okay? To simplify that even further, if you haven't been very active and you're quite sedentary, or maybe you're still really compromised from effects of chemo and radiation, and it's a struggle to get through your daily activities, you might want to start at the 30 to 50% range. And I'm not good with numbers, so 50 works better for me because it's half. So half of 180 gives me 90 beats per minute. So for me, if I was not very active, really feeling tired, and I wanted to start a new exercise program, say walk around the block, my target range might be between 30 and 50%, and when I stop and check my heart rate, I'm going to be somewhere between that 70 and 90 beats per minute. If I'm a little more physically active, then I want to be maybe in the 50 to 65 range, so my target heart rate would be somewhere between, say, 90 and 120. And if I'm more physically fit, yeah, I've been working out on a regular basis, I've got big guns, I'm going to be a little further, maybe into the 120 to 150 range, okay? So now that you know what intensity you need to exercise at, what kinds of exercise count? So aerobic exercise includes walking, biking, swimming, tai chi, anything that you like to do that gets your body moving. And why I highlight walking on a treadmill, stationary bike, cycling, those kinds of things, sometimes there are side effects from our chemo and radiation that affect how we're able to perform activities, including exercise. So if you're really having an issue with peripheral neuropathy and kind of feeling awkward, and maybe you're scared of having a fall outside on the ice and fracturing some bones because of some metastases, a safe thing might be to walk on the treadmill. It's a little more closed, safe environment. Caution, however, if you have extensive metastases in your femurs or your pelvis, you're going to avoid an incline. And you may want further just instruction or direction from your physician or your oncologist about certain parameters that you might want to follow to make your exercise safely, or to make your exercise safe. But in general, aerobic activities, 3 to 5 times a week. You want to target exercising for 30 minutes continuously, but it's okay if you can't do that the first time you go out. There's a cumulative effect. So if the first day you can only make it once around the block, and let's say it's 5 minutes or 10 minutes, or maybe you don't have a half hour uninterrupted time to do your exercise, you can chunk it and do 10 minutes in the morning, 10 minutes in the afternoon, 10 minutes at night. And if 10 is all you can do today, that's great, that's a good start. Maybe tomorrow or next week or a few days later, you'll do a little bit more. So any exercise is better than no exercise, but your goal is going to be 30 minutes at that moderate intensity level 3 to 5 times a week. And if you're going to do more aerobic activities, you're going to decrease the duration and work at a lighter intensity. So let's talk a little bit about strength training. Strength training is great for your muscles and for your bones. The only way you get more energy is if you have stronger muscles, because then they have more energy to help you do what you want to do. So we want you to target large muscle groups like the chest, the back, the arms, the abdomen, and legs. It is safe to lift weights. You want to start with a very light weight and talk to your therapist or to your physician or oncologist if you have some concerns in terms of metastases. For people with metastatic lesions in their bones, I recommend avoiding jarring exercises where you're jumping high intensity or anything with elastic bands because you can't control the force, okay? Again, you're going to start with a light weight, progress slowly. Start maybe with 2 sets of 10 repetition, and once you can manage that, increase to 2 sets of 15 repetitions, maybe even up to 3 sets of 15 repetitions. When you can comfortably do that, if it's a goal of yours to increase your weights, then you're going to drop your number of sets and your repetitions back down to 2 sets of 10. And again, frequency would be 3 times weekly with a day of rest in between for muscle recovery. Okay? And if you want to know if you're working hard enough, you can check your heart rate or just the simple, am I sweating, am I talking a little harder? So we talked a little bit about medical approval and some of those considerations if you have metastatic lesions in your bones. Also, if you've got surgical wounds, you may have restrictions put upon you by your surgeon in terms of range of motion, lifting restrictions, or even weight bearing if there's a fracture or anything like that. If you're undergoing chemotherapy or radiation, things like swimming may be contraindicated because of exposure to bacteria and being in the pool. And also, in terms of chemotherapy, sometimes if you have a portacath or a PICC line that's inserted, the nurses may give you some restrictions in terms of how much they want you to lift with that arm or range of motion. If you have questions, just bring them up with your medical team and get some more specific directions in terms of what you can and can't do. Avoid vigorous exercise on days when you're receiving blood tests or you have to go to the lab. And I mentioned the immunosuppressive effects of high intensity exercise. Contraindicated during treatment because the drugs that you're on already have an immunosuppressive effect on your body and you don't want to double that up. I do caution you, if you experience any of the signs and symptoms that are listed there, to stop exercising. If they don't go away immediately, then you need to seek medical attention. They may be a sign and symptom that you're just working a little too hard, or maybe it's a low day for you, or maybe it's a cycle within your chemotherapy where your blood levels are low. But if the side effects don't go away, or they recur, you want to seek medical attention immediately. If your pulse is racing, if you have a fever and it's persistent, if you develop acute pain, and it could be calf pain for a sign of a clot, or it could be pain in bone that's persistent and worsening, nausea, if you feel confused or disoriented, dizzy, develop blurred vision, become suddenly short of breath, or you feel suddenly weak or tired. These may be symptoms of another medical issue that requires attention. So stop exercising and get that attention. In general, if you want to progress your exercises, you're going to increase the frequency and duration before you increase the intensity. You're going to progress slowly and gradually and modify. Oftentimes people come in hospital and they're quite deconditioned and may not have the tolerance or endurance to get up and go for a walk with us. Well, we start with bed exercises, moving those joints and doing the range of motion. Then we work towards sitting. Then we work towards walking. Then we continually add. So if you're at a point now where you don't have the energy to maybe get on the treadmill or the bicycle or go around the block, maybe just a commitment to do a little bit of range of motion is where you're going to start. And that's a good place to start, and that's okay. In general, monitor how you're feeling and keep track. And if you don't already have a plan in place for how you're going to incorporate exercise into your activities of daily living, my challenge when you leave is to list down 5 things that you like to do. And you may have been doing them before, or you may be doing them right now, but 5 things you like to do that count as physical activity. 5 people you can do these activities with, and grab a calendar. We're all more likely to follow through on a plan if it's written down. At least I am, And I think research supports that if there's a plan, you're more likely to be successful in achieving your goal. So keep track of what you do. These are accomplishments. These are milestones. This is, wow, pat on the back for you. You did it. So write down, I exercised 5 minutes on Monday. Felt great or felt lousy. Exercised 10 minutes on Wednesday. Oh, feeling better, getting easier. These are all really good things. So keep track of it, brag about it, talk about it, and find a buddy who's going to go with you and meet you and motivate you. If you have any restrictions, remember safety first and reward yourself. You're worth it. This is for your health and your benefit and your general sense of well-being. So just keep moving, stay active, and remember to keep on sipping when you're exercising. For every 15 minutes of activity that you do, I want you to take in an extra cup of water. These are some additional websites that you can visit, and if you type in a physical activity or physical exercise, there's additional information. But generally, if you have any questions, talk to your healthcare providers and see what they can do to help you out. Thank you very much for your time.